Today we're going to be focusing on central lines. So in today's lab demonstration we're going to be focusing on three separate skills, but we're going to combine them into one. So the skills that we're going to be performing are going to be accessing a portacath, changing a central line dressing change, and de-axing a portacath. So we're going to be doing those for demonstration purposes all in one. So the first thing that we're going to do is check our order. This may be on our MAR, could be on our physician orders, Cardex, care plan, and the order will typically say something along the lines of starting medications, starting fluids, using that portacath. So make sure that your order states that you need to access the portacath for purpose of administering some kind of medication. Also, portacaths, if they're not in use, if they haven't been accessed, they have to be flushed at least every 4 weeks. So this again may be the purpose of why you are accessing them, is to flush the portacath and then to immediately de-access that portacath. So check your order and see what the purpose is. Why are you going to be accessing this portacath? The next thing is gathering your equipment. So equipment that you're going to need is going to be normal saline, and typically it's going to be in a pre-filled syringe. Anytime you are flushing medications through a portacath or any central line, your syringe needs to always be at least 10 milliliters. Doesn't matter how much fluid is inside that syringe, but your syringe size needs to be at least 10. So we have 10 milliliters of saline in a 10 milliliter syringe. We also need heparin, and you need 5 milliliters of heparin, but again, it has to be in a 10 milliliter syringe. So we have 5 milliliters of heparin in that 10 milliliter syringe. The reason behind using the 10 milliliter syringe is the smaller syringes cause too much pressure and can actually cause that portacath to actually burst. So we want to make sure that we're using our larger ones that don't put as much pressure on those lines. And that goes for any central line. We're also going to need an extra mask and this one's going to be for our patient. We're going to need some alcohol preps, a male adapter or a saline lock, a non-coring needle. You'll hear most people refer to this as a Huber needle. That's typically the brand name. It's non-coring, meaning that when we puncture the septum of the portacath, it does not core out or pull out a part of that septum. So when we pull out the needle itself, then there's no holes in that septum, and that's why that portacath can be used for multiple times. So just make sure that you're using the appropriate needle when you are accessing a portacath. When I get it open, I'll show you the tip of it, how it's kind of got a little hook on there, so you can see that angle. Then the other thing that we're going to need is going to be a central line dressing kit change. You'll notice that a lot of your other supplies are located in here. Your sterile gloves, another mask, your transparent dressing, your cleansing agent, tape, anything like that. So just kind of read the label and make sure that you're going to have everything that you need before you get started. So I'm going to gather all my supplies. I'm going to wash my hands. If I haven't already done so, I'm going to go ahead and draw up my saline or my heparin. Most places now are using the pre-filled syringes, but you could be at an institution where you have to actually draw those up from the vials. Remember, with the pre-filled syringes, they typically come with a small amount of air in there, so you have to pull back on the plunger to release that pressure and then push that up to the hub. So you do that for both your saline and your heparin. Once I've got all that done, all my equipment gathered, then I'm going to go into my patient's room, identify my patient, checking their armband, asking their birth date, comparing the two, and making sure that I have the right patient. I'm also going to be identifying myself, explaining that, I'm Miss Shoemake. I'm here to access your portacath. You also want to do any kind of teaching about the procedure. If this is the first time they've had it done, this may be quite lengthy and you may have to go into a lot of details as to what the process is going to contain. If they've had it done several times, they may fully understand what you're going to be doing. So just find out how much information they understand. The next thing that we're going to do is we're going to raise the bed to a good working height so that I can work with the patient. And again, when we raise the bed, remember we always put up the rails first. For demonstration purposes, I'm going to leave the other side down so that you all can see, but we need to put up the other side. I'm going to raise the bed. Then we're going to raise the patient up just slightly, the head of the bed raised. I'm going to go ahead and put this rail down so that it's easier for me to work with my patient. I'm going to go ahead and wash my hands again. The next thing that I'm going to do is I'm going to palpate the skin over the portacath. This is done with a non-dominant hand. So what you're going to do is you're going to take your non-dominant hand and you're going to try to locate. The reason that you're using your non-dominant hand is because in a few minutes when we get prepared, we're going to have the needle in our dominant hand. And that's the part that's going to have the sterile needle in there. So we're going to use our non-dominant hand, and what you're going to do is you're going to try to locate the edges. So that way in a few minutes when we get ready to puncture the septum of the portacath, we know where those edges are. So we're just locating the edges, feeling of that septum inside, and you'll feel it feels a little spongy inside of there, where the edges are hard because of that metal that's surrounding that septum. The other thing that we're doing is looking for any redness or swelling. If there's any redness around that port, induration, swelling, we want to pause and maybe talk to our doctor, talk to the patient, see what's going on, if this is normal for them or if it's something we need to report. We don't want to access anything that already has maybe an active infection going on. So we would just stop at that moment if there's any redness, swelling, induration, report that to the doctor and see where we need to go from here. So for our patient, there's no redness, there's no swelling, so we know that we're good to go on with the procedure. The next thing that we're going to do is we're going to go ahead and get most of our equipment prepared. So what we're going to do is we're going to open up our non-coring or Huber needle. When you open it, what you're going to notice is that the tip of the needle is covered. That is the actual sterile part of this needle. So you just are very careful. So I'm going to kind of show you this without dumping it onto the table. That we have our tubing. We have a piece of tape that's over the butterfly edges of the needle, and then the needle is actually covered. So that is to keep that sterile. So now what I'm going to do, I've got this open. So now I'm going to take my male adapter or your saline lock. I'm going to open it. Take off the cap of your male adapter. I'm going to take off the cap of your Huber needle. So again, it just comes with a cap on it. We want to place a saline lock on there that's easier for us to instill medications. And again, the sterile part is covered. So I'm going to take that off. Apply the saline lock. The next thing that we're going to do is attach our saline, and we're going to flush it just like we did with an IV. We have to flush our tubing so that we don't get an air embolism. So I'm going to flush just enough to get it to the tip of that catheter. Then after I do that, I'm going to leave the saline flush attached, and I'm going to clamp the tubing. So you hear it snap, okay? At this moment, I'm going to lay this back down into my package. Set it to the side. All right, so now what I'm going to go ahead and do is I'm going to go ahead and get my patient masked. If for whatever reason they can't handle a mask, then you can have them turn it to their side. But if they're actively coughing, it's really important. We are accessing a central line. So again, a central line means that the distal tip is located somewhere around the heart. And that's very important because if they get into infection in that can become systemic and cause them a lot of problems. So we want to make sure that this site is protected anytime that it's accessed. So we're just going to place this over our patient. Okay. The next thing that we're going to do is go ahead and open our central line dressing tray. I'm going to set some of my garbage over here to the side. So I'm going to open it up. Remember, that's one of the keys, is making sure you have your table set up into how you need it when you're opening a sterile tray. So inside of my tray is my kind of package. So I can go ahead and open that up, dispose of that. When you open it, you notice that you have your mask, and I would put that on. And just because I'm going to be talking during the demonstration, I'm not going to place this on because it would be difficult to hear me, but I would place my mask on. Go ahead and take out my gloves. Set them to the side. You can go ahead and open your drape. Remember that this is just following sterile technique. Remember that 1 inch around your drape is considered to be non-sterile. Sometimes you just got to work with it a little bit to get it to fall down. In some of the instances, depending on how your tray is packaged, you may have to actually put the gloves on first and then open up your tray. So I'm going to go on over here, open up my sterile gloves, again just using sterile technique. Remember, when you're sterile gloving, you put on your dominant hand first and you pick up the glove by the cuff. And I typically hold it up, stand back. If we get our lobster hands, we can fix that. Okay. So next we're going to grab our other glove inside the cuff. Pick that up, step back, holding our thumb of our dominant hand back so that we don't contaminate that glove. So now I've got that one on, so now I can fix this. Don't worry too much about the cuff because that part's not really considered sterile. So next I'm going to get rid of my paper using your elbow. The next thing that we're going to do is now prep our site. So I'm going to go here to my sterile field, and you'll see that you have several pieces of equipment in there. You can just kind of separate it out. So this one has the chlorhexidine. So what you're going to do is you're going to squeeze the wings of this and you'll hear it break. Okay, so we're going to start in the middle of the port, and we're going to make a circular motion. Cleaning around the edges. Okay. Once I'm done with that, then I can throw that away. The next thing I'm going to do is make sure that this is dry. Again, any type of solution that you're using to clean, the main thing is to make sure that it's dry. So allow that to dry. The next thing that we're going to do is we are going to use our non-dominant hand now to pick up the syringe part that's attached to our Huber needle. Again, just like some other skills that we've done, we're going to keep our sterile hand, our dominant hand sterile, and our non-dominant can be non-sterile. So I'm going to pick this up. So again, remember the part that we're worried about is the tip end. So we're going to go ahead and take this tape off. You just have to work with it a little bit. We're going to pull back our edges of our butterfly. Get those held back. And then what we're going to do is very carefully you are going to take the cap off of it. Again, making sure that you're not touching the end of the needle. So I'm just going to pull that off. And again, if you can see, it kind of has kind of a little angle to the needle. Okay, so the next thing that we're going to do is now we are going to take our non-dominant hand and we're going to locate the middle of the septum. What we're going to do is we're going to take our needle, we're going to go into a 90-degree angle. So we found the edges of the port, right into the middle in a 90-degree angle, we're going to go straight down. Sometimes when you press down, you can feel kind of a hardness where you've hit the back of that septum of the portacath. All right, so now we have the needle inside of the portacath. So now what we're going to do is we are going to unclamp, and now we're going to check for placement. So what we're going to do is we've unclamped and now we're going to aspirate. We should see blood coming back into our tubing and our syringe. If you don't, if you look at your lab manual, there are 3 things that you need to attempt. So we're going to aspirate for blood return. So again, withdraw that flash of blood to check the needle. If there is no blood return after we've aspirated, then what we may want to do is we may just want to reposition the patient. Put them higher, turn them a little bit, because sometimes the portacath is positional. So we're going to try that. After we've repositioned, again, we're going to aspirate again. If there's still no blood return, then what we're going to do is we're going to try flushing with just about 1 to 2 milliliters of normal saline. It should feel very smooth as it pushes through. If you're having to push or feeling resistance, then it's still not in there. Then, if there is still, we've flushed some saline, we're going to aspirate again. If there's still no blood return, then we're going to remove the needle, get a new needle, and try to re-access that. If after that point we've tried a new needle, we've tried all those other things again with that new needle, then we're going to call the doctor, and more than likely they're going to order an x-ray to see if that portacath is in the right place. So once we know that it's in there, then we are going to stabilize that needle, which is what I'm doing, just holding down the wings. We're going to flush with 10 milliliters of saline. So we've aspirated, we got blood, now we're going to flush with 10. While we're flushing, we're looking around the site to see if there's any swelling, if we're feeling any resistance. Again, it should be rather smooth. There should not be any swelling around the portacath site. So we're going to flush with that whole 10, just nice and smooth. Once we get the 10 in, then what we're going to do is we're going to clamp. It's very important when you're dealing with the central line that when you are taking syringes on and off, that you make sure that it's clamped before you take it off, because otherwise that could pull air back up into it. So we've clamped it. Next thing that we're going to do is we are going to take off our saline. Here, depending on what you've accessed the port for, you can either attach your fluids, or if we're just doing it to flush for our monthly flush, then we are going to now attach our heparin. Cleaning this time because we've taken something off. So you just see that I'm using my one hand to stabilize, my other hand so attach my heparin, unclamp, flush with my 5 milliliters of heparin. Again, clamp, take it off. Okay. If you look at your lab manual, it talks about that if the needle does not sit flush, some people's portacasts kind of jut out from their skin, then you may have to put a piece of gauze underneath there to stabilize that. If we are going to use this, we've accessed it and we're going to be using it for fluids or medications, then what we're going to do is we're going to now put the dressing on top of it. We want to use a transparent dressing so that we can see and make sure there's no redness, swelling around that site. Again, we want to make sure that it's clamped. You may have to put another piece of tape there if it dangles. Okay, and like I said, in your package you have some tape, you have some gauze in case you need to put around it. Some of the kits may actually have some skin protectors because for some people the occlusive dressing is very irritating to the skin. Once we've got it stabilized and secured, then we're going to take off our gloves, wash our hands. Our syringes are going to go into the sharps container. We're going to take our mask off our patient. Get rid of all of this. Put them back in a comfortable position. So raise our rails again. Lower them down. Whatever position is comfortable for them. And then we make sure that we document. Alright, so after we've done that, we've documented, we're going to go ahead and go on to the next part of this, which is de-accessing the portacath. So I'm just going to take a minute here and kind of throw all this to the side. And I'll talk while we are getting rid of everything. Alright, so de-accessing means that the patient no longer needs the access. So again, either they have had fluids or medications and they no longer need that, or again we're doing our monthly flush where we would access it, flush with the heparin or the saline and the heparin, and then de-access that. So it depends again on the purpose of your accessing and de-accessing the portacath. So again, we're going to refer to our medical record. The equipment that we're going to need for this time is going to be again alcohol preps. Again, we're going to need a 10 milliliter syringe filled with 10 milliliters of saline, 5 milliliters of heparin in a 10 milliliter syringe, clean gloves. Okay, so again, we're going to wash our hands. We're going to pull up our saline and heparin if we didn't already have that done. And again, remember that these come with air already instilled. So what we're going to do is take off the cap, pull back and break that seal, and then push up to get our saline right at the hub of this syringe. Same thing with the heparin. Pull back, then push that up to the hub. Alright, so we're going to take our equipment into our room. We're going to identify the patient, again checking name, asking them their birth date. We're going to introduce ourselves. Again, if they've never had it de-accessed, that was the very first time that you accessed it, and this is the very first time you're de-accessing it, you again may go into a little bit more detail. If they've had this several times, you may just have to tell them that you're going to de-access their porta-cat. So again, we're going to raise the bed to a good working height, and for demonstration purposes, I'm just going to keep up the one closest to me, but I would put up the other side. Raise the bed. Just like we did with accessing, we're going to put their head slightly up. We're going to lower the rail on the side that we're working on. Wash hands, put on my clean gloves. Next thing that we're going to do is go ahead and flush our lines, first with our saline and then with our heparin. These are to make sure that this porta-cat remains patent. So we're going to clean with alcohol. Grab our saline. Again, we're going to unclamp. Flush with the tin. Again, this is to make sure that this line is going to remain patent, because there is a line that is attached to the porta-cat that is located around the heart. Clamp again, take off our saline, clean, 30 seconds. Now we're going to attach our heparin. Remember, heparin is an anticoagulant, so hopefully it will keep this line from clotting. Unclamp, flush with our 5 milliliters of heparin. Clamp. Take off our syringe. Now, the next thing that we're going to do is we're going to remove the old dressing. So remember that anytime you're trying to get off tape or transparent dressing, if you will use some alcohol, that helps to get the tape off of the patient just a little bit easier. When you are taking off a central line dressing, you always go from bottom to top. The reason you don't go from top to bottom is that you may accidentally pull out the needle before we're ready to pull it out. So you always work bottom to top. And again, just using that alcohol to moisten the skin. Getting that off. If this one dries out, then just get another one. Sometimes if you'll hold down on their skin and pull at the same time as well. Okay, once we get a little bit closer to the needle, I'm just kind of holding pressure there so I make sure that I don't pull that out before I'm ready. Sometimes you can get the dressing all the way off. Sometimes you just have to leave it attached to the wings of your okay. I'm just going to wad that up in my hand. Alright, so the next thing that we're going to do is now we're going to remove the needle. So we're just going to grab the wings. With our non-dominant hand, we're just going to hold on, putting pressure so that when we pull it out, we don't pull the patient's skin too much. we're just going to pull out at a 90-degree angle. So we're holding with our non-dominant hand. We're going to pull the needle out. This is going to go into our sharps. So I'm going to go put it in the sharps. Depending on our patient, we might just need a little Band-Aid there. It depends on how much they bleed from that site. Next, I'm going to wash my take my gloves off, wash my hands, get rid of all my equipment. My syringes are going to go into the sharps. Everything else, I'm just going to throw it away. Put my rails back up, lower the bed, get them into a comfortable position. Make sure that they have their call light, anything else that they need. Go ahead and put my rails down. And then I'm going to document the procedure.